All right, everyone. Welcome to Chapter 12, where we move north on the body map and spend some quality time in the oral region, the upper respiratory tract, and the ear. This chapter is basically the front door of the human body. Everything comes through here, so air, food, pathogens, bad decisions, all of it. From a histology standpoint, this region is incredibly busy. You'll see rapid epithelial turnover, constant exposure to environmental irritants, a mix of stratified squamous, respiratory epithelium, glandular tissue, cartilage, bone, and sensory structures. So if you've ever looked at a head and neck slide and thought, why does this look like five tissues arguing with each other? You're not wrong. Clinically, these tissues are essential for breathing, speaking, swallowing, and hearing. And yes, even tasting food before we decide whether it's worth finishing. Some worthless but fun knowledge is that the oral cavity and upper respiratory tract are exposed to more external pathogens per day than almost any other body system, second only to the GI tract. Your mouth is basically a very social environment. By the end of this chapter, you should be comfortable recognizing normal histology of oral and respiratory tissues, common inflammatory and infectious conditions, and how subtle epithelial changes can signal major disease processes. Here's how this chapter breaks down, nice and organized, just the way histotechnologists like things. We'll cover three major sections. Components of the head and neck. This is our anatomy and histology foundation. We'll focus on oral cavity structures, salivary glands, upper respiratory epithelium, and the ear, which is histologically way more interesting than it gets credit for. Number two is the symptoms, signs, and tests. This section connects what we see under the microscope to real clinical practice. Think why hoarseness matters, why chronic mouth ulcers are never just irritation, and why biopsies from this region are extremely common in pathology. And then number three, specific diseases. This is where pathology really shines. Infections, inflammatory disorders, autoimmune conditions, and malignancies that love epithelial tissue just a little too much. From a lab perspective, head and neck specimens are common, small, and deceptively complex. Orientation, margin identification, and proper fixation matter a lot here. So yes, this is one of those chapters where histology and clinical relevance truly overlap. Let's start with the oral cavity, which is doing far more than just housing teeth. The oral cavity is responsible for mastication, which is mechanical digestion, swallowing, which is a coordinated neuromuscular miracle, breathing, especially when noses fail us, taste, and speech. Histologically, it's a high traffic area with constant mechanical stress, which explains why most of it is lined by stratified squamous epithelium. Sometimes keratinized, sometimes not, depending on the location. Some key structures are the teeth. From a pathology perspective, teeth themselves don't come through the histology lab often, but the surrounding tissues absolutely do. Think gingiva, periodontal ligament, and bone. Then we also have the tongue. The tongue is skeletal muscle arranged in multiple directions, which is why it looks so chaotic under the microscope. It's covered by stratified squamous epithelium and houses papillae, taste buds, and minor salivary glands. Fun histology clue is if you see skeletal muscle running in three directions at once, you're probably in the tongue. We also have walls of the mouth. These are constantly exposed to friction, heat, trauma, and microbes, which explains why dysplasia and carcinoma often develop here. This is also why oral biopsies are extremely common. And lastly, salivary glands. Salivary glands provide moisture, lubrication, enzymes for digestion, and antimicrobial protection. Think of saliva as the body's built-in mouthwash, just less minty. We have the parotid glands, which are mostly serous acini, so watery, enzyme-rich. We have the submandibular glands, which is mixed with serous and mucus. And then we have the sublingual glands, which is mostly mucus acini. Then there's minor salivary glands, which are scattered everywhere throughout the oral mucosa. Histology tip you'll absolutely need to know. Serous acini stain dark and have a granular cytoplasm. Mucinous acini stain pale and have foamy cytoplasm with flattened nuclei. If it looks like bubble wrap, you're in mucus territory. Some worthless knowledge. Humans produce about 1 to 1.5 liters of saliva per day, most of it without ever noticing, unless something goes wrong. All right, now we're at the front door of the respiratory system. Let's start with the nose, which honestly does not get enough credit. The nose is responsible for respiration, moisturizing and filtering air, and smell, which means every breath you take is being conditioned before it ever reaches the lungs. Think of the nasal cavity as a high-end HVAC system. It warms the air, humidifies the air, and filters debris, all before the air hits your delicate alveoli. Histologically, this is why we see respiratory epithelium here. So pseudostratified ciliated columnar epithelium with some goblet cells. These cilia are sweeping mucus posteriorly like tiny janitors with brooms, constantly moving dust, bacteria, pollen, and whatever else you inhaled towards the pharynx to be swallowed. Yes, your lungs stay clean because your nose turns dirt into stomach acid soup. The sinuses lighten the skull, add resonance to your voice, and drain into the nasal cavity. When they're inflamed or blocked, you feel pressure because those air spaces suddenly become fluid-filled, which histologically means edema and inflamed mucosa. Now let's move back to the pharynx, the shared hallway between the respiratory and digestive systems. The pharynx conducts air, participates in swallowing, and plays host to immune surveillance. The tonsils, which we have 3 different types, palatine, pharyngeal, and lingual, are part of MALT, M-A-L-T, or mucosa-associated lymphoid tissue. Histologically, they're packed with lymphocytes sitting just beneath stratified squamous epithelium. They're ready to fight whatever wandered in. And then there's the eustachian tubes that connect the nasopharynx to the middle ear, equalizing pressure. This is why your ears pop on airplanes and why upper respiratory infections love to turn into ear infections. Fun but annoying anatomy teamwork, right? Next stop, the larynx, also known as the body's most dramatic organ. The larynx is responsible for maintaining an open airway, protecting the lower respiratory tract, and producing sound. It's multitasking at its finest. The epiglottis is the flap that decides whether something goes to the esophagus or the trachea, and when it chooses incorrectly, you experience the panic known as, "Why am I choking on water?" Histologically, this is one of my favorite concepts. The epiglottis is covered by stratified squamous epithelium on the lingual side, which is the food side, and then respiratory epithelium on the laryngeal side, which is the air side. So remember, form follows function, always. The true vocal cords are covered in stratified squamous epithelium because vibration causes friction and mechanical stress. The false vocal cords, which don't vibrate much, retain respiratory epithelium. So if you ever see stratified squamous epithelium deep in the airway, ask yourself, is this vibration or protection? The question alone can get you several histology exam points. So some worthless knowledge is that your vocal cords vibrate between 100 to 250 times per second during speech. That's why inflammation, edema, or nodules drastically affect voice quality. You're trying to vibrate swollen tissue at jet engine speeds. Now let's talk about the ear, which is doing far more than just letting you hear me lecture. The ear has 2 major responsibilities, hearing and balance, and both rely on extremely specialized structures. The vestibular apparatus, including the semicircular canals, is your body's built-in level and motion detector. Tiny hair cells shift with movement, converting physical motion into electrical signals. If those hair cells are damaged, that's vertigo. The room spins even when you're not moving. Histologically, those sensory cells are incredibly delicate and do not regenerate, which is why balance disorders can be long-term. The ossicles, which includes the malleus, the incus, and the stapes, are the smallest bones in the human body. Together, they amplify sound vibrations from the tympanic membrane to the inner ear. Fun fact, the stapes is about the size of a grain of rice, and without it, hearing efficiency drops by roughly 60%. The cochlea is where mechanical sound waves become neural signals. Inside is the organ of Corti, sitting on the basilar membrane with exquisitely arranged hair cells that respond to a specific frequency. So high pitch is at the base of the cochlea and low pitch is at the apex. This means your cochlea is literally frequency mapped like a biological graphic equalizer. We also see important supportive structures here. So large skeletal muscles controlling head and neck movement, the thyroid gland, which we've talked about already, and then lymph nodes, which are extremely important clinically because head and neck cancers often metastasize early via lymphatic drainage. This is why pathologists pay very close attention to cervical lymph nodes in biopsies and dissections. So before we jump into disease processes, we need to orient ourselves because pathology only makes sense when you know what belongs where. This slide gives us a roadmap of the oral cavity, upper airway, and ear, which are all tightly connected anatomically, functionally, and pathologically. Think of this entire region as shared real estate. Everything is packed close together, and when something goes wrong in one structure, it very often affects its neighbors. On the left image, we're seeing the oral cavity and the upper airway. Key structures here include nasal cavity and sinuses, the nasal conchae and the medius, the nasopharynx, the oropharynx, and the laryngopharynx. We have the hard and soft palate, the uvula, the tonsillar tissue, the tongue, epiglottis, vocal folds. From a histology perspective, this region is fascinating because it contains multiple epithelial types packed into a very small space. You'll see stratified squamous epithelium in areas exposed to friction, like the oral cavity and the oropharynx. You'll see pseudostratified ciliated columnar epithelium in respiratory regions. You'll see specialized olfactory epithelium high in the nasal cavity. So one continuous anatomic pathway transitions through several epithelial environments. And that becomes extremely important when we talk about inflammation, infection, and neoplasia. Histology fun fact. If you follow the airway from the nose to the bronchi, the epithelium changes multiple times, and tumors almost always arise from the epithelium native to that specific region. That's why squamous cell carcinoma loves the oral cavity, while respiratory epithelium produces very different tumor types deeper in the airway. So location matters. Functional overlap equals pathological overlap. Another important takeaway from this image is that the oral cavity serves three jobs simultaneously: respiration, digestion, and communication. That means inflammation, masses, or structural changes here can cause difficulty chewing, difficulty in swallowing, voice changes, airway obstruction, which is why relatively small lesions can create big clinical problems. The right image is of our ear anatomy. So it's divided into three major components: the outer ear, which is for sound collection, the middle ear, which is for sound amplification, and then the inner ear, which is balance and neural signal conversion. The middle ear connects directly to the nasopharynx via the eustachian tube, which is why upper respiratory infections, sinus inflammation, and allergies can so easily lead to otitis media, especially in children. Again, shared real estate. Each portion of the ear has distinct tissue features. The external auditory canal has stratified squamous epithelium, the middle ear has respiratory type epithelium, and then the inner ear has highly specialized neuroepithelium. Damage to each region produces very different clinical outcomes, even though they're physically close together. And once we get into the inner ear, especially the cochlea, damage is often permanent because those sensory hair cells do not regenerate. This slide sets the foundation for everything that follows in this lecture. As we move into inflammatory conditions, infectious diseases, autoimmune disorders, neoplastic processes, you should always ask yourself, what tissue type normally lives here? What function does this structure serve? How would damage appear microscopically? And what symptoms would that structural change cause? If you understand the anatomy and histology first, the pathology becomes much easier to interpret. This is the part where pathology starts showing up before the specimen ever hits the lab. When we talk about symptoms, signs, and tests, remember that everything we see under the microscope starts with someone saying something doesn't feel right. Clinicians often begin with palpitation and visual inspection on physical exams, basically hands-on detective work, right? Palpation of the neck helps identify enlarged lymph nodes, swollen salivary glands, firm fixed masses that make everyone a little nervous. From a histology perspective, this is why neck dissections and lymph node biopsies are so common in head and neck pathology. For the ear, an otoscope allows visualization down the ear canal to check for infection, fluid buildup, and tympanic membrane damage. And for the throat, laryngoscopes are used to evaluate vocal cords, epiglottis, and suspicious lesions. A fun histology reminder, the vocal cords look dramatically different depending on whether you're on the true cords, which are stratified squamous epithelium, or the false cords, which are respiratory epithelium. One vibrates and one just hangs out and provides backup vocals. Some radiological techniques. Imaging helps guide where the biopsy comes from. So x-rays are commonly used for teeth. They're helpful for abscesses, impactions, and bone involvement. CT scans are excellent for sinus disease. They show fluid levels, mucosal thickening, and bony erosions, and they're often used to map tumor extent before surgery. MRIs, these are best for soft tissues. They're critical for tongue, salivary gland, and deep neck masses. And then we have the fluoroscopy, which evaluates swallowing function. Think of it as a live action movie of aspiration risk. Some worthless knowledge here. Radiologists love CT for bone, MRI for soft tissue, and pathologists love whatever comes with a requisition that actually tells us the clinical history. Some other diagnostic tests are the audiometers. So these measure hearing function, especially important in inner ear disorders. There's microbiology, so used for suspected bacterial or fungal infections, especially relevant in chronic otitis media or sinusitis. And then biopsies, which are our favorite part. These are used to determine inflammatory versus neoplastic, benign versus malignant, and reactive versus something much more serious. This is where histology truly enters the chat. Now we move from how we find problems to what the problems actually are. Diseases of the oral cavity, upper respiratory tract, and ear fall into three broad categories. Genetic and developmental diseases, such as cleft palate, congenital hearing loss, and structural airway abnormalities. These often present early in life and can dramatically affect speech, swallowing, and breathing. Histologically, many show abnormal epithelial development, altered cartilage formation, and disrupted tissue organization. Think of it as architecture problems. The blueprint itself had issues. Next, there's inflammatory and degenerative diseases. These are extremely common and include sinusitis, otitis media, tonsillitis, and chronic laryngitis. From a slide perspective, you'll often see edema, increased vascularity, inflammatory infiltrates, goblet cell hyperplasia, chronic inflammation that can lead to epithelial metaplasia, thickened basement membranes, and fibrosis. So basically, long-term irritation makes tissues start remodeling like they're on an HGTV show nobody asked for. And then lastly, we have neoplastic diseases. Head and neck cancers are especially significant because they affect speech, impact swallowing, and involve critical nerves and lymphatic drainage. Many arise from stratified squamous epithelium and salivary gland tissue, which means, yes, you will see a lot of squamous cell carcinoma in this region. And yes, lymph nodes matter tremendously here due to early metastasis. This slide sets the stage for the specific conditions you'll encounter. So again, genetic and developmental diseases often involve abnormal fusion of tissues, defective cartilage or bone formation, and improper epithelial differentiation. So common examples include cleft lip and palate, congenital ear malformations, and developmental abnormalities of the nasal cavity or sinuses. You may see discontinuous epithelium, disorganized connective tissue, abnormal muscle orientation, or poorly developed glands. These specimens can be subtle, not dramatic tumors, but they require excellent orientation, careful embedding, and thoughtful sectioning. because sometimes the diagnosis depends on how things are arranged, not just what cells look like. So a final takeaway for this slide are symptoms guide testing, imaging guides biopsies, histology provides the final diagnosis, and in the head and neck region especially, structure and function are inseparable. If you mess with airflow, sound conduction, salivary production, or swallowing mechanics, you change quality of life in a very real way, which is why precision in the histology lab truly matters here. So these conditions are different from what we've discussed so far in other chapters because they're not acquired later in life. They arise from abnormal development, altered gene expression, or disrupted embryologic fusion. Okay. In other words, the tissue didn't become diseased. It never formed normally in the first place. So to begin with, we have malocclusion, which it simply means improper contact between the upper and lower teeth. This isn't just a cosmetic issue. Malocclusion can interfere with mastication, which we know is chewing, speech articulation, temporomandibular joint mechanics, and long-term enamel wear. From a histology standpoint, the tissues themselves are usually normal. The problem is architectural alignment, not cellular pathology. Think of it like a perfectly good door installed crooked in the frame. The door isn't broken, it just doesn't close correctly. Then we have deafness. So deafness is one of the most common developmental disorders involving the ear. About half of all cases are genetic, while the other half are due to intrauterine infections, most notably rubella. That distinction is important because the underlying pathology is very different. We have syndromic versus non-syndromic deafness. Approximately 1/3 of genetic deafness is syndromic, meaning it occurs alongside other abnormalities such as craniofacial defects, renal disease, or skeletal anomalies. However, the most common form is non-syndromic deafness. This is why most children born with hearing loss are actually born to hearing parents. Histology connection is that in non-syndromic deafness, the mutation often affects genes responsible for ion transport, electrochemical gradients, and inner ear fluid balance. And these proteins are critical for maintaining the ionic environment of the cochlea, particularly potassium concentrations required for hair cell depolarization. So even though the cochlea may look structurally intact under the microscope, the electrophysiology fails. This is a great reminder that not all disease is visible on H&E. Sometimes the tissue is there, it just doesn't work. Then we have the cleft lip and cleft palate, which result from failure of embryologic fusion during facial development. So cleft lip occurs when the upper lip fails to fuse on one or both sides of the midline. Cleft palate involves incomplete fusion of the hard or soft palate. These defects form very early in gestation, often before a pregnancy is even recognized. Some clinical implications. Although these defects can usually be surgically corrected within the first 2 years of life, they can create significant complications, including feeding difficulties, speech impairment, recurrent ear infections, hearing loss, balance issues, and difficulties with mastication. Again, the issue is primarily structural, not inflammatory or neoplastic. So most cleft lip and palate cases are sporadic, meaning they occur without a clear inherited pattern. They often result from a combination of genetic susceptibility, environmental exposures, and timing during embryologic development, which makes prevention challenging and highlights the importance of early intervention. So across all of these conditions, the key concept to remember is this. Genetic and developmental diseases reflect errors in formation, not tissue injury. Histology may appear subtle or even normal. Function is often impaired due to architecture, signaling, or connectivity, rather than cell death or inflammation. This is why clinical history and developmental context are absolutely essential when interpreting tissue findings. This slide gives us a visual comparison of cleft palate alone versus cleft lip with cleft palate. And it's helpful because it reinforces something important. These are not cosmetic differences. They represent distinct embryologic failures that occur at specific developmental time points. On the left, we see isolated cleft palate. Here, the upper lip forms normally, but the palatal shelves fail to fuse at the midline. That fusion normally occurs between weeks 6 and 9 of gestation, and if that process is interrupted, even briefly, the result is a persistent opening between the oral and nasal cavities. On the right, we see cleft lip with cleft palate, which involves a more extensive failure of fusion. In this case, the maxillary prominences fail to fuse with the medial nasal processes affecting the lip. The palatal shelves also fail to close, extending the defect posteriorly. So this isn't a bigger cleft, it's a different developmental pathway that went off course earlier in embryogenesis. So what this looks like histologically, from our perspective, these defects are important because the epithelium itself is usually normal. The problem is absence of tissue continuity, not abnormal cells. So you're not seeing dysplasia, inflammation, or neoplasia. Instead, you're seeing interrupted stratified squamous epithelium, exposed underlying connective tissue, and altered muscle attachment and orientation. The architecture, not the cells, is the pathology. Because the oral and nasal cavities are no longer separated, this can lead to feeding difficulties due to loss of suction, aspiration risk, recurrent otitis media from eustachian tube dysfunction, and speech impairment related to airflow escape, also conductive hearing loss. So even though this is classified as a developmental anomaly, its downstream effects span multiple organ systems. Most cleft lip and palate cases are correctable surgically, often in staged procedures within the first 2 years of life. However, long-term management frequently involves speech therapy, audiology follow-up, dental and orthodontic intervention, ongoing monitoring of middle ear disease, and which is why multidisciplinary care is essential. From a pathology standpoint, this slide reinforces an important theme you'll see throughout this lecture. Developmental diseases are defined by where tissue is missing, not by what the tissue looks like under the microscope. Histology helps explain consequences, but embryology explains the cause. So now that we've reviewed genetic and developmental conditions of the head and neck, we're shifting gears into a new category of disease processes, inflammatory and degenerative diseases. These conditions are extremely common in clinical practice and represent many of the diagnoses you will encounter in both surgical pathology and routine histology specimens. Unlike developmental disorders, which arise from errors during embryogenesis, inflammatory and degenerative diseases are typically acquired over time. They develop in response to infection, repetitive irritation or trauma, autoimmune processes, age-related tissue wear, environmental exposures, and in many cases, multiple factors contribute simultaneously. Inflammatory diseases involve activation of the immune system and are characterized by increased vascular permeability, infiltration of inflammatory cells, tissue edema, and possible epithelial damage or ulceration. Depending on the duration and cause, inflammation may be acute, which is dominated by neutrophils, or chronic, which is involving lymphocytes, plasma cells, macrophages, and fibrosis. These processes can significantly alter tissue architecture and function. Degenerative diseases, on the other hand, reflect progressive structural decline rather than active immune attack. They often include loss of specialized cells, thinning or atrophy of epithelium, decreased regenerative capacity, gradual functional impairment. Degeneration is commonly associated with aging, but may be accelerated by inflammation, ischemia, or mechanical stress. From a histology standpoint, inflammatory and degenerative diseases are important because they often appear together in the same tissue. Chronic inflammation frequently drives degeneration. Subtle architectural changes may carry diagnostic significance. You will be expected to recognize cell patterns, distribution of inflammation, evidence of chronic injury, and structural remodeling or scarring. Often the diagnosis depends not on a single feature, but on the overall tissue pattern. All right. So, welcome to the part of pathology that makes everyone suddenly very invested in brushing their teeth. So, let's start with dental caries, aka cavities, or as histologists like to think of them, a microbial demolition project sponsored by sugar. Histologically, this all begins with bacteria adhere to the tooth surface within dental plaque. These bacteria metabolize sugars and produce acids, and those acids slowly demineralize enamel and dentin. Think of enamel like the ceramic coating on your car. Once it's cracked, everything underneath is fair game. If the erosion continues, the damage can extend into the pulp, which contains connective tissue, blood vessels, and nerves. And that's when we get pulpitis. And yes, that's why tooth pain can feel like someone plugged your trigeminal nerve into a wall socket. If left untreated, complications can include tooth loss, periapical abscesses, granulomas, and cyst formation. From a histology standpoint, we often see chronic inflammation, necrotic debris, bacterial colonies, and reactive connective tissue changes. Root canal therapy removes the infected pulp, which is basically pathology's version of eviction without mercy. Now, let's move to periodontal disease, the quiet villain of adult dentistry. Unlike cavities, periodontal disease is often painless, chronic, and low-grade inflammation, which is exactly why it's so dangerous. The inciting factor is usually plaque accumulation between the tooth and gingiva, leading to gingivitis. Over time, inflammation causes gingival bleeding, pocket formation, and bone resorption. Eventually, the inflammation spreads into the alveolar bone, resulting in loosening and eventual loss of the tooth. Histologically, you'll see inflamed gingiva connective tissue, plasma cells and lymphocytes, breakdown of periodontal ligament fibers, and bone remodeling and resorption. A fun but depressing fact is that periodontal disease is the leading cause of tooth loss in adults. So yes, flossing is not a scam. Okay, now that we've talked through the mechanisms behind dental caries and periodontal disease, this slide lets us visually compare how those processes affect different parts of the tooth and the surrounding tissue. Even though these conditions are often discussed together clinically, they are pathologically very different diseases. Let's start on the left. Periodontal disease. What's being illustrated here is a disease of the supporting structures, not the tooth itself. Notice that the damage is centered around the gingiva, the periodontal ligament, the alveolar bone, and the tooth crown may appear relatively intact early on, but the foundation holding the tooth in place is being destroyed. As plaque accumulates along the gingival margin, chronic inflammation develops, the gingiva becomes edematous and friable, a periodontal pocket forms, and bone resorption progresses apically. This explains why periodontal disease is often painless for many years, yet ultimately leads to tooth mobility and tooth loss. Histologically, this correlates with dense chronic inflammatory infiltrates, predominantly lymphocytes and plasma cells, ulceration of the junctional epithelium, and progressive alveolar bone loss. So periodontal disease is best thought of as a chronic inflammatory bone disease of the oral cavity. Now compare that to the image on the right, the dental caries. Caries begin at the surface of the tooth, not in the soft tissues. Here the damage progresses in a very predictable direction. It goes from enamel to the dentin to the pulp. Rather than inflammation being the initiating event, the primary mechanism is acid-mediated demineralization caused by bacterial metabolism of sugars. As the lesion deepens, the dentin tubules provide a pathway for bacteria. The pulp becomes inflamed, pulpitis develops, and infection can extend beyond the apex of the tooth. At that point, inflammation becomes dominant, but only after structural destruction has already occurred. This slide highlights an important distinction you should always make when evaluating oral pathology as histotechnologists. Periodontal disease destroys the support system. Dental caries destroy the tooth itself. They may coexist, but they are not the same disease process. From a specimen perspective, periodontal disease often yields inflamed gingival tissue and bone fragments. Caries-related pathology may include necrotic pulp, abscess contents, or periapical inflammatory tissue. Understanding where the disease starts helps you interpret what tissue you're actually looking at under the microscope. If you remember nothing else from these two slides, caries equals chemical destruction first, inflammation second. Periodontal disease is inflammation first, structural destruction follows. So let's talk about something that no one wants to discuss, but everyone has experienced at least once. Halitosis, or as the slide politely says, bad breath. Halitosis is usually caused by either pungent foods or bacterial breakdown of amino acids within the oral cavity. Those bacteria produce volatile sulfur compounds, which are exactly as unpleasant as they sound. From a microscopic standpoint, this often reflects heavy bacterial colonization, accumulated debris, and poor oral hygiene. Now, when halitosis becomes severe, we may be dealing with acute necrotizing ulcerative gingivitis, also known historically as trench mouth. Yes, actual trenches, as in World War I. This condition involves fusiform and spirochetal bacteria, tissue necrosis, ulceration, extremely foul odor, and gingival bleeding and pain. Histologically, you'll see necrotic epithelium, dense bacterial infiltrates, acute inflammation, tissue destruction. So poor oral hygiene allows these bacteria to overgrow and accumulate metabolic waste, essentially turning the gingiva into a very unhappy biofilm experiment. Treatment includes antimicrobial mouthwash, antibiotics if needed, mechanical debridement, and consistent oral hygiene. In pathology terms, remove the bacteria or they will absolutely not remove themselves. And next up is a virus that never truly leaves, and that is herpes simplex virus type 1, or HSV1. Once acquired, usually in childhood, HSV1 establishes latency within sensory neurons, particularly the facial and trigeminal nerve ganglia. And when I say latency, I mean the virus has moved in, unpacked nothing, and refuses to leave. During periods of stress, trauma, illness, or sun exposure, the virus reactivates and travels down the nerve to the epithelium. This results in painful vesicular lesions, blistering around the lips, gums, or hard palate, and local inflammation. Histologically, classic findings include ballooning degeneration of epithelial cells, multinucleated giant cells, nuclear molding, and Caudraii type A intranuclear inclusions. Yes, this is one of those rare moments where your exam slide might actually look like something in the textbook. Primary infection usually occurs in childhood and may be mild or asymptomatic. Reactivation is what causes the recurrent cold sores. Importantly, HSV1 can also be associated with pharyngitis, lymphoadenopathy, fever without primary infection. And worthless but fascinating knowledge is this: HSV1 can remain latent for decades and reactivate without warning, meaning your immune system and herpes have a very long-term relationship. Across these oral inflammatory diseases, the key microscopic themes you should recognize are epithelial breakdown, bacterial colonization, acute versus chronic inflammatory infiltrates, tissue necrosis, bone remodeling, and viral cytopathic effects. And as histotechnologists, your role is huge because oral tissues often arrive fragmented, inflamed, calcified, or coated in bacterial biofilm, which means decalcification quality, orientation, and section thickness matter immensely for accurate diagnosis. On this slide, we're looking at two very common oral conditions that students will encounter both clinically and histologically: halitosis and herpes stomatitis. The image on the left illustrates one of the most frequent causes of halitosis or persistent bad breath, bacterial plaque, accumulation along the teeth and gingival margins. As bacteria break down food particles and amino acids in the oral cavity, they release volatile sulfur compounds, which are responsible for the characteristic odor. This process becomes more pronounced when oral hygiene is poor, salivary flow is reduced, or plaque and calculus are allowed to build up over time. In more severe cases, halitosis may be associated with acute necrotizing ulcerative gingivitis, where the fusiform and the spirochetal bacteria overgrow and produce tissue necrosis, inflammation, and malodor. From a tissue perspective, this condition is associated with surface epithelial ulceration, dense bacterial colonization, acute inflammatory infiltrates within the gingiva. Again, treatment focuses on improving oral hygiene, including mechanical plaque removal, antimicrobial mouth rinses, and when needed, antibiotic therapy. The image on the right shows herpes stomatitis, commonly referred to as a cold sore. This condition is caused by the herpes simplex virus type 1. After the initial infection, which usually occurs in childhood, again, the virus does not leave the body. Instead, it becomes latent within the sensory nerve tissue, again, particularly the facial and trigeminal nerves. Under certain conditions, such as physical or emotional stress, illness, trauma, or sun exposure, that virus can reactivate. Reactivation leads to the formation of those painful vascular lesions along the lips, gingiva, or hard palate. These vesicles often rupture, leaving shallow ulcers that crust during healing. Histologically, herpes lesions demonstrate, as we said previously, ballooning degeneration of epithelial cells, multinucleated giant cells, and viral cytopathic changes within the stratified squamous epithelium. While the infection is typically self-limiting in immunocompetent individuals, the lesions can be recurrent and uncomfortable, and viral shedding may occur without visible sores. So together, these conditions highlight an important concept in oral pathology. Relatively minor disruptions in microbial balance or viral latency can produce very visible and clinically significant disease, even when deeper tissues remain structurally intact. For histotechnologists, recognizing the inflammatory patterns, epithelial damage, and surface changes associated with these disorders helps connect what you see grossly and clinically to what appears microscopically on the slide. All right. We'll talk about, again, something that everyone has experienced at least once in their life. It's aphthous stomatitis, better known as canker sores. These are painful, localized lesions inside the oral cavity, typically found on the non-keratinized mucosa, so like the inner lip, the cheek, or the soft palate. And yes, they always seem to appear exactly where your teeth rub every time you talk or chew. Histologically, these lesions represent localized mucosal ulceration. The surface epithelium breaks down, exposing the underlying connective tissue. This triggers acute inflammation, neutrophil infiltration, and local edema, and pain out of proportion to size. In other words, tiny lesion gives a massive attitude. These ulcers are typically shallow, discrete, and painful. They're also surrounded by a reddish inflammatory halo, often covered by a yellow-white fibrinous exudate. Think of them like the oral mucosa equivalent of scraping your knee, but with saliva, bacteria, and constant movement, making everything worse. They usually heal on their own within 7 to 10 days, which is great, unless you keep biting it, poking it with your tongue, or eating citrus fruit like you're daring the universe. Worthless but interesting knowledge is that canker sores are not viral and are not contagious, which makes them completely different from cold sores, even though patients confuse them constantly. Some common triggers include minor trauma, like biting your cheek, acidic or citrus foods, nutritional deficiencies, especially B12, folate, or iron, certain medications, autoimmune conditions, and stress, because of course stress is always involved. Treatment is usually supportive, so address the underlying cause, topical corticosteroids or anesthetics if severe. Otherwise, time does the healing. Your body just needs a few days to calm down and stop attacking itself. Now let's shift from the mouth straight into the upper respiratory tract. Upper respiratory infections are among the most common diseases worldwide, and yes, they are the reason your entire lab is coughing by week 3 of winter semester. Clinically, URIs present with a combination of sore throat, which is pharyngitis, nasal discharge, which is rhinitis, headache, fever, and fatigue. A general feeling of I should not be at work today. Additional symptoms can include muscle aches, cough, and sinus pressure. Histologically, these infections primarily affect the respiratory epithelium, which means ciliated pseudostratified columnar epithelium, goblet cell hyperplasia, increased mucus production, vascular congestion, and inflammatory cell infiltration in the lamina propria. So translation, the tissue becomes swollen, sticky, irritated, and terrible at moving mucus, which is why everything backs up. Most URIs are self-limiting, meaning they simply run their course over days to weeks, but they are also highly contagious, spreading through airborne droplets, coughing, sneezing, and touching surfaces and then your face, which us humans do constantly. Histology fun fact, when inflammation damages cilia, mucus clearance slows dramatically, creating the perfect environment for secondary infection. That's why a simple cold can turn into sinusitis or pneumonia if things linger too long. All right, so let's talk cause. Viruses are the usual suspects. These account for the vast majority of upper respiratory infections. So common culprits include the rhinovirus, which is the most common, the coronavirus, yes, many strands existed long before 2020, the adenovirus, and the parainfluenza. So viruses damage epithelial cells directly, triggering inflammation and mucus overproduction, but antibiotics do absolutely nothing here. What brings us to an important lab-based reality check. Bacterial causes. Much less common but clinically important. Group A, Streptococcus, Bordetella pertussis, Haemophilus influenza, and of these, only group A strep is routinely treated with antibiotics, and only after confirmatory testing. This is why throat cultures and rapid strep tests matter. Histologically, bacterial infections tend to show more intense neutrophilic infiltration, thick purulent exudate, and greater epithelial destruction. The best prevention remains immunization, good hygiene, limiting exposure when symptomatic. Vaccines dramatically reduce complications, especially in the vulnerable populations. URIs are usually mild, but not always. So high-risk groups include children, elderly patients, and immunocompromised individuals. Some potential complications include otitis media, enlarged tonsils with airway obstruction, sinusitis, and pneumonia. One important pediatric complication is croup, characterized by laryngeal inflammation and subglottic narrowing. This involves a distinctive high-pitched inspiratory stridor. Histologically, this reflects mucosal edema and inflammation in an already narrow airway, which is why even mild swelling can cause dramatic symptoms in children. Kids aren't just smaller adults. Their airways are proportionately narrower, so a little swelling goes a long way. Oh. We'll talk about sinusitis, otherwise known as why does my face feel like it's going to explode when I lean forward? Sinusitis is an inflammation of the mucosa lining the sinus cavities. Remember, these sinuses are normally air-filled spaces lined by respiratory epithelium. Pseudostratified ciliated columnar epithelium with goblet cells during their mucus-making thing. When inflammation hits, several things happen at once. The mucosa swells, the sinus openings narrow or become blocked, normal mucus drainage stops, so instead of nice flowing clearance, mucus gets trapped and fluid begins to accumulate. Think of the sinuses like a bathroom sink. If the drain is open, no problem. If the drain clogs, suddenly everything backs up, and that's sinusitis. Sinusitis can occur for different reasons. So anatomic causes like a deviated septum or secondary inflammation, usually from a viral upper respiratory infection or allergens. Once fluid accumulates, it becomes a warm, moist environment, basically an Airbnb for bacteria. We classify sinusitis as acute sinusitis, which lasts less than 1 month. It's usually viral and often self-limited, or chronic sinusitis, which persists longer than 1 month or keeps reoccurring, and it's often associated with polyps, chronic inflammation, or structural abnormalities. Some common symptoms include nasal congestion, headache, and facial pressure, thick mucoid discharge, and postnasal drainage, everyone's least favorite sensation. Treatment focuses on symptom relief, so saline washes, decongestants, and pain medications. Most cases resolve on their own. Antibiotics are reserved for situations where secondary bacteria infection is suspected. Not every stuffy nose needs amoxicillin, despite what your grandmother on Facebook believes. On slides, you'll often see thickened respiratory mucosa, edema of the lamina propria, and increased goblet cells. Sometimes maybe even chronic inflammatory infiltrates. Some worthless knowledge: the maxillary sinuses drain upward against gravity, which is one reason they're the most commonly infected. Poor design choice. Poor design choice. Next up is allergic rhinitis, also known as hay fever, which is misleading because it's rarely caused by hay and it doesn't cause fevers. So really, it's a terrible name. Allergic rhinitis is an IgE-mediated hypersensitivity reaction to environmental antigens. So translation, your immune system sees harmless pollen and says, absolutely not. When allergens are inhaled, IgE antibodies bind mast cells. Mast cells degranulate, histamine, leukotrienes, and prostaglandins are released. And suddenly we get a runny nose, sneezing, itchy eyes, and a scratchy throat. Basically, your immune system throws a tantrum. This condition is often seasonal because trees, grasses, pollen, and flowers, or perennial, which is dust mites, animal dander, molds. It's also frequently associated with asthma, eczema, and especially in children. Allergic rhinitis is more common in urban environments, in males, and in children who were bottle fed rather than breastfed. And it can absolutely be hereditary. While not life-threatening, it can significantly affect quality of life. So chronic fatigue, obstructed breathing, poor sleep, difficulty concentrating, and learning and memory impairments. So yes, chronic allergies can make people feel like their brain is operating on dial-up. Chronic inflammation can also lead to nasal polyp formation, which you'll see histologically as edematous mucosa, loose connective tissue, dense eosinophilic infiltrates. Eosinophils are your histologic clue that allergies are involved. If you see a lot of them, think hypersensitivity. Treatment options include antihistamines, decongestants, steroids, either topical or systemic, eye drops, and desensitization therapy, such as Allerase shots. Best treatment, though, avoid the trigger, which sounds easy until you realize pollen exists literally everywhere. Fun fact, people with allergic rhinitis often develop the allergic salute, that habitual upward nose wipe, which can cause a transverse nasal crease over time. Histology doesn't show it, but clinicians absolutely notice it. Now let's move into the ear, specifically otitis media, or inflammation of the middle ear. This is incredibly common, especially in infants and young children, and almost always follows an upper respiratory infection. Here's what happens. During a URI, inflammation causes swelling in the nasopharynx. That swelling can obstruct the eustachian tubes, which normally help equalize pressure between the middle ear and the outside world. When those tubes are blocked, air is absorbed from the middle ear. Negative pressure develops. Fluid seeps into the middle ear cavity. So that fluid is now sitting behind the tympanic membrane, warm, moist, and stagnant, which makes it a perfect breeding ground for bacteria, and sometimes even fungi. Viruses alone can cause otitis media, but secondary bacterial infections are very common. Fluid accumulation causes significant pain, especially in children who can't explain what's wrong, hence the screaming at 2 a.m. Diagnosis is often done with an otoscope, where clinicians may see a bulging tympanic membrane, redness, and loss of light reflex. Not all cases require antibiotics. Many are viral and resolve spontaneously. However, complications can occur. Suppurative otitis media is pus-forming bacterial infection. The tympanic membrane may rupture, which may rarely relieve pain, but risks spread of infection. Severe or untreated cases can spread to the base of the skull or even into the brain. Chronic infection can lead to a formation of a cholesteatoma, which, despite the name, is not a tumor and does not contain cholesterol. It's actually an abnormal collection of keratinizing squamous epithelium that erodes middle ear structures and can cause permanent hearing loss. Histologically, cholesteatoma shows stratified squamous epithelium, keratin debris, and chronic inflammation. Treatment depends on severity and may include antibiotics, pain control, or surgical placement of ear tubes to restore ventilation. Children are more prone to otitis media because their eustachian tubes are shorter, wider, and more horizontal. Basically, the anatomical equivalent of poor drainage. All right, let's pause and actually look at what's happening anatomically, because this image explains about 90% of why otitis media hurts so badly. On the left, you'll see the external ear, which includes the ear canal, not the problem child today. The real drama is happening in the middle ear, that air-filled space behind the tympanic membrane. Under normal conditions, the middle ear is ventilated by the eustachian tube, which connects the middle ear to the nasopharynx. Its job is simple: equalize pressure and drain fluid. But here's the problem, especially in kids. The eustachian tube is shorter, narrower, and more horizontal, which makes it about as effective at drainage as a clogged sink. When inflammation from a URI causes swelling near the pharynx, the eustachian tube narrows. Air can't enter the middle ear, negative pressure develops, and fluid gets pulled into the space. Now we've created a warm, moist, nutrient-rich environment, which bacteria absolutely love. Histologically, this means inflamed respiratory epithelium, increased mucus production, neutrophils, macrophages, and exudate filling the middle ear cavity. And because the tympanic membrane can't move freely anymore, sound conduction drops, hence temporary conductive hearing loss. Some worthless but useful knowledge is that this pressure buildup is why kids will often tug at their ears. They're instinctively responding to mechanical discomfort, not just pain. So when you hear fluid behind the ear, this is what that actually looks like in real life. Now let's talk about hearing loss, which is not a single disease. It's more like a symptom with many possible villains. Hearing loss can result from genetics, infections, trauma, aging, medications, and noise exposure, or basically life. There are two major types, and histology helps us understand both. So the first one is conductive hearing loss, and this happens when sound can't physically move through the ear. Problems occur in the external ear and the middle ear. Common causes include otitis media, fluid accumulation, damage to the ossicles, and otosclerosis. Histologically and anatomically, the tissue is mechanical. The vibrations simply can't get transmitted efficiently. Think of it like trying to hear music through a wall instead of an open doorway. And then we have sensorineural hearing loss. This one involves damage to the cochlea, the hair cells, or the auditory nerve. Once those hair cells are gone, they are gone. They do not regenerate, which makes this type permanent. This is the type seen with noise exposure, ototoxic drugs, infections, and aging. There's hearing loss in children. In kids, hearing loss is often congenital and infectious, and the most common cause? Chronic or recurrent otitis media. Repeated inflammation damages middle ear structures and interferes with normal auditory development. Age-related hearing loss is presbycusis, and this is due to gradual degeneration of the hearing apparatus over time. Key features here include loss of high-frequency hearing first, often associated with tinnitus. Affects about 60% of people over the age of 73. Histologically, we see degeneration of hair cells, reduced blood flow, and accumulated lifetime damage. Fun fact, the I can hear you, but I can't understand you complaint is classic high-frequency loss. Consonants live in the high-frequency range. Other notable causes is otosclerosis, which is an abnormal bone growth in the middle ear. This prevents the ossicle vibration, and it often affects young women. And then there's Meniere's disease. It's a degenerative disorder of the vestibular apparatus. Causes vertigo, tinnitus, and hearing loss, and can be profoundly debilitating. Treatment ranges from hearing aids, cochlear implants, to surgical prosthesis. All right, now let's head south from ears to saliva. Salivary glands don't usually get much attention until they stop working, and then everyone suddenly cares a lot. Here we have mumps. Mumps is a viral infection caused by a paramoxovirus. Before vaccination, it was one of the most common childhood illnesses. The virus primarily targets the parotid glands, leading to parotitis, which is painful glandular swelling, fever, and difficulty chewing and swallowing. Histologically, we see inflammatory infiltrates, edema, and acinar cell dysfunction. Sometimes scleroliths, salivary stones, can form and obstruct ducts, worsening the inflammation. Some worthless knowledge here. Those classic chipmunk cheeks you see in photos, that's bilateral parotid swelling. Vaccination has dramatically reduced incidence, which is why outbreaks are now mostly seen in under-vaccinated populations. And then we have Sjogren's syndrome. Sjogren's syndrome is an autoimmune disorder that specifically targets salivary glands and the lacrimal glands. The immune system mistakenly destroys the glandular epithelium. Histologically, this is very distinctive. We'd see dense lymphocytic infiltration, progressive acinar destruction, and replacement with fibrotic tissue. The result is xerostomia, which is dry mouth, keratoconjunctivitis sicca, which is dry eyes. Patients often report difficulty swallowing, dental caries, oral infections, and eye irritation, because saliva plays a major role in lubrication, buffering acids, and antimicrobial defense. Its absence can cause severe dental and mucosal damage. This condition also commonly overlaps with rheumatoid arthritis, lupus, and other immune diseases. So whether we're talking about viral destruction, as in mumps, or autoimmune destruction, such as Sjogren's, the underlying tissue is the same: loss of functional glandular epithelium. So no acini equals no saliva. And histologically, that loss explains every clinical symptom. Okay, on this slide, we're putting visuals to the processes we just discussed, specifically how salivary gland dysfunction actually presents in the body. So let's start with, on the left, with mumps. What you're seeing here is the classic parotid gland swelling, also called parotitis. The virus has a strong preference for salivary gland tissue, particularly the parotid glands, which explains why the swelling is so dramatic and so visible along the jawline. At the tissue level, this swelling reflects viral infection of ductal and acinar cells, inflammatory edema within the gland, and compression of ducts, which can further impair saliva flow. Histologically, affected glands show interstitial edema, lymphocytic infiltration, and temporary disruption of acinar architecture. This is not a permanent destruction process. In most patients, the glandular tissue recovers once the infection resolves. Now, shifting to the right side of this slide, we have the Sjogren's syndrome, and this is where the pathology becomes very different. Unlike mumps, which is infectious and acute, Sjogren's syndrome is autoimmune, chronic, and progressive. Here, the immune system specifically targets the exocrine glands, specifically salivary glands and the lacrimal glands. Microscopically, this disease is characterized by dense lymphocytic infiltration, gradual acinar cell destruction, and replacement of functional gland tissue with inflammatory cells and fibrosis. As acini are lost, saliva production decreases significantly. That loss of saliva explains many of the clinical symptoms shown here. So persistent dry mouth, increased dental caries, oral yeast infections, difficulty speaking and swallowing, and accelerated enamel breakdown. From a histotechnology perspective, this is important because the gland may appear firm, enlarged, or nodular grossly, yet microscopically shows loss of secretory units rather than infection. So while both conditions involve the salivary glands, their mechanisms are completely different. Mumps is acute viral inflammation with gland swelling. Sjogren's syndrome is chronic autoimmune destruction with gland failure. One causes temporary dysfunction, the other causes permanent structural damage. Understanding that difference helps explain why symptoms may look similar on the surface, such as swelling, dryness, and discomfort, but the underlying tissue pathology is fundamentally distinct. Deep breath, everyone. We've officially entered the neoplastic disease section. Anytime time you see the word neoplastic, your brain should immediately translate that to abnormal, uncontrolled cell growth. Not all neoplasms are malignant, but all of them involve cells that have stopped listening to the rules. Neoplastic diseases in the oral cavity, upper respiratory tract, and ear are especially important because these tissues are constantly exposed to inhaled substances, environmental toxins, infectious agents, and mechanical trauma, which means the epithelium here is under constant stress and regeneration, a perfect setup for DNA errors. From a histology perspective, this region is dominated by stratified squamous epithelium, high cellular turnover, and frequent exposure to carcinogens. So when dysplasia begins, it often starts in the epithelium and progresses stepwise. Hyperplasia, dysplasia, carcinoma in situ, and then invasive carcinoma. That progression is something you'll see again and again throughout pathology. As histotechnologists, this is our bread and butter territory. Neoplasms of the head and neck region frequently require small biopsies, marginal excisions, and orientation critical specimens. Careful margin evaluation as well. A poorly embedded or improperly oriented specimen can literally change a patient's treatment plan. These cancers can significantly affect speech, swallowing, facial structure, breathing, and quality of life, which is why early detection and good histology matters. Some worthless but useful knowledge here is the head and neck region contains over 30 different tissue types packed into a very small anatomic space. That's why pathology reports here can feel very dramatic. Bone, cartilage, muscle, glands, epithelium, lymphoid tissue, sometimes all in one specimen. Fun for us, terrifying for residents. Squamous cell carcinoma is the most common primary malignancy of the head and neck, and that makes sense when you think about the tissue types lining this entire region. Much of the oral cavity, pharynx, larynx, and upper airway is lined by stratified squamous epithelium, which means those cells are continuously exposed to mechanical irritation, chemical injury, inhaled toxins, ultraviolet radiation, and chronic inflammation. Over time, repeated injury increases the risk for malignant transformation. Squamous cell carcinoma can arise in several locations, including the mouth, tongue, pharynx, tonsils, and larynx. It can also develop on the lip or the earlobe, particularly in areas exposed to chronic sunlight, again, highlighting the vulnerability of squamous epithelium. From a risk factor standpoint, this tumor is strongly associated with tobacco and alcohol use. These substances cause ongoing epithelial injury, promote dysplasia, and impair normal DNA repair mechanisms, creating an environment where malignant clones can develop and expand. Clinically, treatment often involves surgical excision, which may be curative if detected early. However, because of the anatomic complexity of the head and neck, excision can come at a cost, including loss of speech, swallowing, or mastication, and is often followed by radiation or chemotherapy depending on the tumor stage. Prognosis depends heavily on tumor size at discovery, lymph node involvement, and presence of metastasis. Early detection makes a major difference. Symptoms are highly location dependent. Patients may present with hoarseness or voice changes, difficulty swallowing, pain or bleeding, or visible oral lesions. Grossly, these tumors typically appear as expanding masses, ulcerated lesions, or thickened, crusted plaques. On the tongue, white patches known as leukoplakia may be present. These represent areas of epithelial dysplasia that can precede carcinoma. Not all squamous cell carcinomas arise from smoking or alcohol exposure. Some cases are associated with human papillomavirus or HPV, particularly tumors located in the posterior oral cavity, base of the tongue, and tonsillar region. HPV-associated tumors tend to occur in younger patients and, importantly, often have a better prognosis than those related to tobacco or alcohol. These same viral strains are also implicated in carcinoma of the cervix, reflecting shared molecular mechanisms of oncogenesis. Another virus linked to head and neck malignancy is the Epstein-Barr virus, or EBV. EBV is associated with infectious mononucleosis and undifferentiated nasopharyngeal carcinoma. These tumors are often more prevalent in parts of Asia and Africa and are often poorly differentiated histologically, but tend to respond well to radiotherapy. From a histotechnology perspective, squamous cell carcinoma is defined by invasive nests or cords of malignant squamous cells, cellular atypia, increased mitotic activity, and in well-differentiated tumors, keratin pearl formation. Recognizing how normal stratified squamous epithelium transforms into invasive carcinoma is essential for understanding both diagnosis and disease progression. In short, squamous cell carcinoma represents a disease of chronic epithelial injury influenced by environmental, viral, and lifestyle factors, with clinical outcomes closely tied to early detection and tissue involvement. Slide is where things get a little uncomfortable, but also very real. These images show classic gross presentations of oral squamous cell carcinoma, and they are a good reminder that cancer does not usually look neat, symmetric, or polite. Some gross features you'll commonly see: irregular masses, ulcerated lesions, and thickened, indurated tissue. Areas that look inflamed, necrotic, crusted, or frankly, angry. These lesions tend to bleed easily, have uneven borders, persist instead of healing, and grow outward and downward into underlying tissue. In other words, they don't respect boundaries. Why these lesions are often missed early is because early squamous cell carcinoma can look deceptively mild: a white patch, a red patch, a sore that won't go away, something blamed on a sharp tooth or a denture irritation. By the time lesions resemble the images you see here, the tumor has usually been present for months. From our side of the microscope, these gross lesions usually correlate with thickened squamous epithelium, loss of normal maturation, dysplasia progressing to invasion, and irregular nests and cords of malignant squamous cells. Also keratin pearl formation in well-differentiated tumors. That ugly surface appearance, that's reflecting chaos happening all the way down at the cellular level. Think of normal stratified squamous epithelium like a well-organized layer cake. Basal layer at the bottom, maturing cells moving upward, and keratin neatly on top. Squamous cell carcinoma is what happens when the cake collapses, the layers forget their jobs, and someone keeps baking anyway. These specimens are often irregularly shaped, ulcerated, fragmented, and difficult to orient, which makes grossing absolutely critical. If margins aren't inked correctly or orientation is unclear, the depth of invasion may be underestimated, margins may be uninterpretable, and the final diagnosis may lack essential staging information. This is where histotechnologists quietly become the heroes. The images demonstrate squamous cell carcinoma involving the lateral tongue, which is a very common site, the ventral tongue, the flora mouth, and the posterior oral cavity. These areas are especially vulnerable due to thin mucosa, high cell turnover, and chronic chemical exposure, such as smoke, alcohol, reflux, and irritation. A fun but slightly disturbing fact is that the tongue is one of the most metabolically active skeletal muscles in the body. High turnover equals more cell division. More cell division equals more opportunity for mistakes. Cancer tends to show up where biology works the hardest. So, take home message. These images remind us that squamous cell carcinoma is not subtle, it's not uniform, it's not predictable, but it is highly dependent on early recognition, strongly influenced by specimen handling, directly impacted by histology quality, and what we do in the lab absolutely matters. Salivary gland tumors are uncommon overall, but when they do show up, they show up with style and variety. These tumors are kind of the grab bag of head and neck pathology. Salivary gland tumors are rare, but represent a wide variety of tumor types, both benign and malignant, which means two things. You won't see them every day, and when you do, they look very different from one case to the next. The majority of salivary gland tumors occur in the parotid gland, and here's the good news. Most parotid tumors are benign. That's a huge clinical relief, especially given the facial nerve runs right through the parotid like it owns the place. Some worthless but memorable knowledge. If a salivary gland tumor is in the parotid, odds favor benign. If it's in a minor salivary gland, like the palate, that's where malignancy becomes more likely. Location really matters. Pleomorphic adenoma. This is the rock star of salivary gland tumors. Accounts for over 50% of all salivary gland neoplasms. It's usually benign and slow growing. It's most commonly found in the parotid gland. Histologically, these tumors are famous because they contain epithelial components. They're stromal, so mesenchymal appearing components, in wildly variable proportions. Hence the name pleomorphic, which means many forms. Pleomorphic adenomas are the trail mix tumors. You never quite know what you're going to get. You can see ducts, myoepithelial cells, myxoid stroma, cartilage-like areas. It's one tumor pretending to be five. The most common malignant salivary gland tumor is the mucoepidermoid carcinoma. This tumor contains a mixture of mucus-producing cells, squamous cells, and intermediate cells, which makes the histology especially interesting and occasionally challenging. Some known associated risk factors include smoking, radiation exposure. However, and this is important, most cases are idiopathic, meaning patients often did nothing wrong. Sometimes cells just misbehave. Why this matters in histotechnology is that salivary gland tumors demand excellent technique because architecture is key, subtle cellular differences matter, margins are critical, and tumors may look deceptively bland. A beautifully processed slide can make the difference between benign mixed tumor and low-grade malignancy or something much more aggressive. Salivary gland tumors may be uncommon, but they are histologically fascinating, structurally complex, and clinically important, and they remind us that not all tumors follow simple rules. Sometimes pathology likes to keep things interesting. This image shows a pleomorphic adenoma of the parotid gland, the most common salivary gland tumor you'll ever encounter. On gross exam, these tumors are typically well circumscribed, lobulated, firm but rubbery, and often appear encapsulated. But don't trust that capsule completely. More on that in a minute. Cut surface is classically variegated, tan to white, with blue-gray translucent or myxoid areas. That mixed appearance directly reflects what's happening microscopically. Pleomorphic adenomas are one of the best examples of how histology explains gross morphology. Why does it look so mixed? Well, because the tumor contains epithelial ductal structures, myoepithelial cells, and stromal components that can appear myxoid, chondroid, which is cartilage-like, or hyalinized. So when you slice it open, you're basically seeing multiple tissue personalities living together in one mass. This tumor is the pathology version of a layered dessert. Every slice looks slightly different depending on which component you hit. Although these tumors appear well circumscribed, they are not always truly encapsulated. Microscopically, pleomorphic adenomas can send out small finger-like projections beyond the apparent capsule, and this matters because incomplete excision can result in reoccurrence. Reoccurrences may grow slowly and quietly over years, which is why surgeons take margins seriously even for benign tumors. On the clinical image to the right, you're seeing a classic palatal mass. It's firm, painless swelling, slow growing, and often discovered incidentally. The overlying mucosa is usually intact. Minor salivary gland tumors frequently occur in the hard palate, the soft palate, or the upper lip. And unlike the parotid, minor salivary gland tumors are more likely to be malignant, which is why these lesions always get biopsied. This is one of these tumors where slide quality truly matters. You're often differentiating pleomorphic adenoma versus low-grade mucoepidermoid carcinoma versus adenoid cystic carcinoma. Subtle differences in architecture, stromal texture, and cellular arrangement can completely change the diagnosis. Beautiful fixation and sectioning make that possible. Pleomorphic adenoma may be benign, but it is anything but boring. Most common salivary gland tumor, most commonly in the parotid. It's mixed epithelial and stromal components, characteristic variegated gross appearance. It's an excellent example of histology explaining gross pathology. If you understand this tumor, you understand salivary gland pathology at its core. All right, up to this point, we've talked a lot about structure. Now we need to talk about what happens when that structure stops doing its job. In the head and neck, organ failure doesn't usually mean the organ disappears. It means function is lost. And in this region, function matters a lot. The head and neck are responsible for several essential daily activities, including eating, swallowing, breathing, speaking, and hearing. When disease interferes with any of these, quality of life can decline rapidly, even if the pathology itself isn't immediately life-threatening. Loss of mastication. This can occur due to oral cancers, jaw involvement, painful mucosal lesions, and tumor resections. Even partial loss of chewing ability can lead to poor nutrition, weight loss, and difficulty maintaining hydration. Think of mastication as the first mechanical step of digestion. If that step fails, everything downstream suffers. Then we have loss of deglutition, which is swallowing. Swallowing is a beautifully coordinated process involving the tongue, the pharynx, the larynx, cranial tissues, or cranial nerves, and skeletal muscle. Tumors or inflammation affecting any of these structures can result in dysphagia, aspiration, or chronic pneumonia risk. Histologically, even small lesions can have large consequences depending on location. We have some obstruction of pharyngeal passages, so that can result in sleep apnea, often caused by enlarged tonsils, soft tissue collapse, or obesity-related airway narrowing. During sleep, patients may stop breathing repeatedly, experience hypoxia episodes lasting up to a minute, and wake feeling unrested despite sleeping all night. This leads to poor sleep quality, daytime fatigue, and cognitive impairment. Sleep apnea is most commonly seen in obese adults and small children with enlarged tonsils. Sometimes the problem isn't microscopic at all, it's purely anatomical. And then there's obstruction by foreign object. So food is the most common culprit. This can rapidly obstruct airflow, lead to asphyxiation within minutes. Emergency intervention may require airway clearance or surgical airway placement or even a tracheostomy. This is a reminder that in the head and neck, millimeters matter. Then there's loss of vocalization, often results from tumors involving the larynx, vocal cord invasion, or surgical resection. Patients may experience hoarseness, weak voice, or complete loss of speech. From a pathology standpoint, even small carcinomas in this area can produce dramatic clinical symptoms due to precise anatomy. Loss of hearing. This is the most common organ failure of the head and neck, Causes include chronic otitis media, ossicle damage, inner ear degeneration, tumors affecting neural transmission. Unlike many other failures, hearing loss is often gradual, progressive, and under-recognized until advanced. In the head and neck, disease impact is less about tumor size and more about where it chooses to live. A tiny lesion in the wrong place can block air, prevent swallowing, silence speech, or eliminate hearing. This is why histology, anatomy, and clinical correlation are inseparable in this region. Because sometimes the best way to end a lecture is with the uvula finally getting the attention it thinks it deserves. This slide is your exhale moment. No new content, no memorization pressure, just reinforcement through humor and anatomy recognition. Some quick anatomy callback. Remember, incisors and molars are for mastication, right? The tongue is used for speech, taste, swallowing, and it's a lesion hotspot. The uvula is that tiny structure, but it's big drama energy. Histologically speaking, the uvula is stratified squamous epithelium. In skeletal muscle core, there's minor salivary glands. It's highly vascular connective tissue. So translation is it's small and floppy, but absolutely not insignificant. Some worthless knowledge. The uvula helps with speech articulation and preventing nasopharyngeal regurgitation. Elongated uvulas can contribute to snoring and sleep apnea, and yes, it can swell dramatically during allergic reactions. It's a tiny structure, but massive personality. So if you take nothing else from today, please respect the uvula. It's been hanging in the back of your throat your entire life, doing its best.